Morning. I'm a little bit hoarse. I'm sorry for that. I want to thank again Dr. Hisham, Ahmed, and Yahya for the great organization of this conference and for inviting me, as well as the chairpersons for having me here today to discuss this issue, which follows the previous speakers of fine-tuning of management of breast cancer. When we talk about adjuvant chemotherapy, it's really going down to the smaller subgroups of patients, particularly those that very small tumors. And here we're talking about those tumors who overexpress or amplify HER2, and to see whether they can be treated or not. If you look at the NCCN guidelines, as always, guidelines give you some general directions, but not details of what to do. And it says that consider chemotherapy with trastuzumab. While this means yes, it means no, and if it means yes, what kind of trastuzumab therapy you want to give these patients, and if there are benefits, what are the benefits, what are the side effects? And these are becoming very big questions that needed to be addressed, particularly when you look at quote-unquote chemotherapy. This is the studies that look at adjuvant Herceptin-based chemotherapy. There are 4 or 5 major studies, and in all of these really treat all comers the same, whether they are several centimeters in diameter, and whether should we apply this to the smaller tumors. And therefore, I want to see if we can dissect this and if we can transfer the benefits that are projected by these studies into the smaller tumors. However, to see if we can approach them with a milder chemotherapy without compromising the benefits. As you can see here from these studies that are done in adjuvant Herceptin-based chemotherapy, that all of them has achieved significant improvement in disease-free survival and overall survival. Not only that, these studies also showed a very therapeutic index, particularly when you talk about cardiomyopathy, and showed that it is extremely very well tolerated. Although the percentages may vary from one study to the other, but please keep note of the definition of cardiac toxicity that varies from one study to the other. However, it remains very acceptable. But the only caveat with these treatments is that you need to follow the cardiac function of the patient when they are treated actively. And I like more music, not talk. Okay, thank you. So close monitoring of cardiac function is very recommended, and there are directions to hold trastuzumab, particularly if there is more than 16% absolute drop in the LVEF, or LVEF is below institutional limits of normal, and 20% absolute decrease in the LVEF. Although if you encounter these situations, there is ample of data published that suggests that this decrease in the LVEF is reversible. And to take it one step further, in many instances, after recovery of the ejection fraction, and if needed, you may reinstitute trastuzumab. Duration of the Herceptin therapy, however, is being studied very carefully, and the study shows that 1 year is better than 2 years. If you use it for 2 years, you increase the risk of cardiomyopathy without improvement of the survival outcome. And in the FAIR trial, looking at 6 versus 12 months, which was a non-inferiority complex, a study showed that 12 months is the preferred duration of therapy. Having said this, what does pertain to our subject today? Shall we take it all, like cut and paste, and use the same treatment and management to a 3 millimeter, 7 millimeter, 1 millimeter? Where do you draw the line? And if there is any benefit from doing that? In this study from British Columbia, a tumor registry suggested that a 10-year relapse-free survival is definitely worse for those patients who have a HER2 overexpressed or amplified than HER2 negative, and the difference was 78 versus 72%, which is significant, and it tells us that the HER2 tumors, even they are very small, that they have a worse prognosis. And here we want to focus more not only the anatomy, which is reflected by the size of the tumor, or for that matter, the state of the lymph nodes, but the biology. Here we started looking at the biology and treating the biology of the tumor. Other two studies, one from MD Anderson, also suggested that those very small tumors, T1A and T1B, and here we're looking at 2, 3, 5, 7 millimeters, showing poor survival, relapse-free survival in the HER2 positive compared to the HER2 negative, 77% versus 94% in the MD Anderson series, and the NCCN series is 83 versus 89%. These differences are statistically significant, whether you look at the relapse-free survival or distant relapse-free survival. In the HER2 negative, it is 77 and 86 respectively, and in the HER2 positive, 77 and 86% respectively, and HER2 negative, the difference is not very much, 94 and 97%. A retrospective study looking at the treatment of these smaller tumors with Herceptin-based chemotherapy outlines significant improvement in the disease-free survival and the overall survival. And in this study, they looked at the tumor categories separately in T1A, which are ER positive and HER2 positive, and showed that the invasive tumor-free survival and overall survival, a 5-year estimate, improved from 86% to 100% and 95% to 100% when you give chemotherapy. And in the tumors that are ER negative and HER2 positive, the improvement in the free survival went up from 84 to 89%, and in the overall survival went up from 93 to 100%. So we understand from these studies that the treatment has its impact on the management of these patients, the control of the disease, and the overall survival. More importantly, in another study, also coming from France, suggested that the patients with smaller tumors that were treated with chemotherapy, not only they benefited, but they were able to identify two subgroups of patients who did better than the others, basically the estrogen receptor negative and the high-grade tumor. So start understanding more about the biology of the tumor, not only the HER2 overexpression or amplification, but also estrogen receptor and the grade may play a role, and this should be accounted for in our future study designs and data analysis. Based on all of this, this is a study that also was detailed yesterday in one of the presentations, looking at taking these smaller tumors and give them adjuvant chemotherapy with the paclitaxel and the trastuzumab, and give the trastuzumab for a longer time. The criticism to this study, although the results answered a lot of questions, the criticism was that they took all tumors that are 3 centimeters or less, although our interests are tumors smaller than 1 centimeter. We know what to do to a tumor less 3 centimeter or 2 centimeter. And also It looked at the side effects of the tumor, but there was no comparison to another line, and therefore we have to take the results based on the historical controls, if you like. So all tumors that were HER2 positive by IHC or by FISH, less than 3 centimeters, node negative, good ejection fraction, no grade 2 in neuropathy in excess of grade 2. All are included in this study. The distribution or the characteristics of the patients was very fair for this patient population. Less than 50 years were 132 or 33% of the patients. T1A 19%, T1B 31% of the patients, which comprise 50% of the group, and grade 3 56% of the group, node negative 33% of the group. The disease-free survival at 3 years, which obviously is short, but maybe an indicator, and hopefully with the future follow-ups will give us more data, showing that the disease-free survival at 3 years is 98.7% for the whole group. And the disease-free survival by tumor size, looking at greater than 1 centimeter versus less than 1 centimeter, suggesting that it is 98 and 99%. And actually, this is the first message coming from this trial, despite the smaller number, despite that the follow-up is short, is that if with this we can achieve very promising results, and if somebody will come on the other side of the fence and say, no, I still want to give TCH, FAC followed by TH followed by FEC, the question is, what is the amount of improvement you can add on top of what you are getting here? Maybe the answer become clearer in favor of more extensive therapy after 10 or 15 years if this curve make a nosedive in the future, which is unexpected. But I think balancing between the additional benefit from more extensive therapy to what we are achieving here, which is a significant increase from the historical control, which is the 85 or 87%, going up all the way to 98. I think this is a major improvement in the therapeutic benefits of this regimen, and it is very important to build on it. However, contrary to what the French people found about stratification of estrogen receptor, and what they reported that ER negative patients did better than ER positive in terms of benefits, here they did not find so far any difference between the ER negative and the ER positive. Therefore, I think this study is a concept, a proof of concept that milder therapy for these smaller tumors is an acceptable approach. However, it remains under research to fine-tune it. And the authors have a very cautionary conclusion, saying that it may be considered as a reasonable approach. In fact, outside of clinical trials for these smaller tumors, we are using it in our center, and we collectively agreed and shifted from giving these same patients FAC and weekly Taxol, which we thought all along that it may be an overkill for the patients, but for lack of a better option, we were been giving it for the past few years until we get this body of data. There was always, nowadays, everything comes up. It was followed immediately with a meta-analysis, which I like those, but I always caution myself when I read a meta-analysis that it may mislead you in about 20 to 30% of the time. for those who want to read more about the statistics, there is the reference is in, I think in I'm sure it is in New England Journal of Medicine in the late 90s, which I forgot the exact reference to that. And in this meta-analysis aimed to identify a group of patients that could be excluded from trials evaluating additional therapy to avoid unnecessary toxicity, and the analysis of disease-free survival and overall survival of patients with a small HER2-positive breast cancer treated with chemotherapy and trastuzumab. The meta-analysis included these major studies where they sorted out the smaller tumors and looked at the benefits from there. And indeed, it was found that patients with a small HER2 breast cancer patients, hormone receptor positive and tumor size less than or equal to 2 centimeters and node negative, have a favorable outcome when treated with standard adjuvant chemotherapy. Again, the standard chemotherapy, we know they are working, we know they are very effective, but again, given the body of data that I presented earlier, does the magnitude of benefit between this aggressive therapy and the weekly Taxol and Herceptin justify the side effects, the cost, and the resources that the patient has to put to get it? In other words, is she getting anything in return from this aggressive therapy? This is yet to be known. However, building on the study that came from Dana-Farber, the weekly Taxol and Herceptin single-arm study, now there is a randomized trial looking at paclitaxel and trastuzumab versus TDM1 or Kadcyla. It's a randomized trial. It's chosen because TDM1 is also well tolerated, certainly much better than AC or FAC or FEC. The other study looking at trastuzumab alone versus TDM alone, and for that matter, it is approved for that reason. Talking about TDM1, and in light of the adjuvant neoadjuvant trials that showed its combination with the taxane and trastuzumab showed to be very effective and give very good results in terms of pathologic remission rate in the NeoSphere trial was 46%, and the Trifina trial was high 50%, 55 to 65%. It was really very logical that we can use this in the adjuvant trials also for these smaller tumors, or at least do subset analysis for the smaller tumors who may receive pertuzumab with trastuzumab and chemotherapy versus placebo plus trastuzumab and chemotherapy. And here, weekly Taxol is the preferred choice to be used in this respect. Therefore, the options of treatment of HER2-positive breast cancer in the adjuvant or neoadjuvant setting is rapidly changing, and if so, it is even more changing, rapidly changing in the smaller tumors, and the regimen specifically available for patients with either small tumors or extensive disease, and ongoing clinical trials with novel HER2 target therapies may expand a treatment option further, and always keep an eye on those small tumor category, and this is what I call it the fine-tuning of treatment of breast cancer. And I finish here.
Thank you, Dr. Nihat.
I always beat the time, huh?
Okay, thank you.
Okay.
Now, the last speaker, Dr. Mohsen Mokhtar. Dr. Mohsen Mokhtar is professor in Cairo University. His talk will be systemic management of bone metastasis in breast cancer.
Okay, thank you very much, Mr. Chairman, for your introduction. I'd like to thank Hisham and the organizers for inviting me to talk about and give this session. My task is to talk on systemic therapy or management of bone metastasis in breast cancer. These are my disclosures, and I'll try and be very quick. I know I'm keeping you up from the prayer, so I'll try and do it in 10 minutes. But to start off, why is bone metastasis very important in breast cancer? Because it is obviously the most common site. Over 70% of patients who have breast cancer at the time of postmortem do have some sort of bone metastasis, and we know that the median survival is around 2 years. But you also have to understand it's totally different when your patient has bone-only metastasis, because these patients actually have a median survival of around 72 months, so that's around 5 years. So they've got a lot of time to develop skeletal-related events, as well as sequencing their treatment is obviously very important. So when do you expect your patient to have bone metastasis? Well, if your luminal A or the luminal subtypes are more likely than the HER2 and the triple negative, obviously. If your patient is a grade 3 tumor, if she has more than 4 positive lymph nodes at time of diagnosis, if your primary tumor is more than 2 centimeters, and if your patient is ER positive, PR negative, they are more likely, and patients who are younger, less than 50 years, are more likely to develop bone metastasis than patients who are older. And if you're concerned with the genetics, if you want to check for genetic expression for your tumor, patients who do have an interleukin-11, metallomatrix protein, chemokine receptor 4, as well as trefoil factor 1 and 3 are more likely to develop bone metastasis than patients who don't. So how does that all fit into the osteomimicry and the bone metastatic model? Once your mammary cells transform and are transformed by mutagenesis into tumor cells, if these patients or these tumor cells express chemokine receptor 4, which is needed for the homing of these tumor cells, which is known as the soil and seed theory, then the connective tissue growth factor, osteopoietin, interleukin-11, as well as trefoil factors that are needed for osteolysis. Once they go and niche in the bone, then these will allow or enhance the osteoblast to release the rank ligand. The rank ligand will go and transform your premature osteoclast to mature osteoclast. Then the parathyroid hormone-related peptide released from the tumor cells will go and further enhance the activity of these mature osteoclasts, releasing cathepsin K, which is needed for the osteolysis. And once that happens, the bone will, in return, do the favor for the tumor cells, releasing transforming growth factor, which will further enhance the tumor cells. So there's your vicious circle. You will also get calcium and N-telopeptide, which can be a measurement of this bone osteolysis. But what we can see here is that we've got also 2 other things that we can target, the cathepsin K as well as the rank ligand when we're targeting bone metastasis. So what do we want to do in terms of goal and treatment of therapy for these patients? We do want to improve their quality of life, obviously, decrease the skeletal-related events, but in the end, we also want to improve the progression-free survival as well as the overall survival. So there are 2 things that we do for these patients. We give bone-directed therapy as well as systemic therapy other than bone-directed therapy. To go on, biphosphonates, we know that the biphosphonates are active in this setting, and we know by now that pamidronate and zoledronic acid are probably the most effective. But what I wanted to show you is this 2 interesting studies. These were released last year and the year before, the ZOOM trial, which compared after giving 9 to 12 cycles of zoledronic acid to be randomized either every 4 weeks to every 12 weeks. And as you can see, there was no inferiority. This was further analyzed in the optimized study. Again, patients receiving more than 9 cycles for bone metastasis of IV biphosphonates, zoledronic acid 4 weeks versus every 12 weeks. The primary endpoint, skeletal-related events. And as you can see, there is no difference. I think that is very important because we can actually be saving our patients the agony of coming in every month for the zoledronic acid as well as the cost of these drugs. And you also get a benefit in terms of adverse events, though it's not really statistically significant, but you do get less renal toxicity as well as less osteonecrosis of the jaw. And this was the conclusion from these 2 trials. Now, for the anti-rank ligand, DMAP was tested versus zoledronic acid from this phase 3 trial, primary endpoint being the skeletal-related event. And as you can see, the skeletal-related event was delayed by around 5 months with the use of DMAP versus zoledronic acid in terms of first skeletal-related event, and again, a 23% reduction versus first and subsequent skeletal-related events, proving that probably DMAP was a stronger drug in this setting. And these are the incremental data coming out of all of these trials, as you can see, going down from 64% to 18% in terms of skeletal-related events. But as you can see, in the end, it didn't transform to an overall survival benefit. Now, as for cathepsin K, ozanimod, which is one of the drugs developed under Merck, and you can see this was a phase 2 trial comparing ozanimod to zoledronic acid, and in this trial they showed that there was equivalent reduction of N-telopeptide, but this was further not analyzed in a phase 3 trial, though we do have phase 3 trials with ozanimod as prevention of osteoporosis of chemo-related therapy or chemotherapy-related osteoporosis. The other novel agents and future directions are obviously coming from the slide that I showed you. Transforming growth factor inhibitors are being tried out. SERC inhibitors such as the dasatinib and sarcatinib have also been tested out in phase 1 and 2 trials, proving that they do have some efficacy. Also, DKK-1 neutralizing antibody is ongoing. They are ongoing trials, but in multiple myeloma. As for systemic radiation therapy, we've known that samarium, strontium, as well as radium do affect and have effect on bone metastasis. But this was a trial with 100 patients. 40 of them had metastatic breast cancer. You do get an improvement in the performance status, improvement in the pain, more favorable results, though, are seen in osteoblastic rather than the mixed tumor. So probably they are better for patients who have prostate cancer rather than patients who have mixed as our patients. Now, after defining all that, there are other therapies. The other therapies, or the other side of the therapy, which is your other systemic therapy, and you do have to define your patient. Now, what I wanted to show you is that we all follow that when we do have a patient with bone metastasis, we tend to sequentially give single-agent chemotherapy for our patients, especially if they are triple-negative or HER2-positive patients. And you can see from this data here that this is a long list of single-agent chemotherapies that give you responses between 28 to even up to 68% of CR and PR, as you can see here. But what I wanted to show you, and I know this is going to be very eyebrow-raising, is that single-agent chemotherapy in a lot of series, vinrolbine, for example, even though you do have a 16% response rate, there is no response in bone. Continuous 5-FU, no response in bone. One of the things that did respond in bone was doxorubicin, taxanes, and as you can see here, the combination chemotherapy, CMF or CAF, you can see that there is up to 60% response in bone. Combination with vinrolbine, also, again, partial response, 50% in bone. So maybe single agents don't work as well in terms of bone. I could not find any data on bone-only metastasis with capecitabine. As for the HER2 therapy or targeted therapy for HER2-positive metastatic breast cancer bone only, these are the data coming out of the Cleopatra and Emilia trial. And if you look at the subset analysis for patients who did not have visceral metastasis, there was no benefit for the addition of pertuzumab to trastuzumab, and there was no benefit of TDM1 versus trastuzumab versus the trastuzumab combination in terms of overall survival or in terms of progression-free survival. As for hormone receptor positive breast cancer, we know that we have a long list of hormone therapy that does effectively work in patients who are hormone receptor positive. We know that now that the aromatase inhibitors are probably slightly better than tamoxifen, whether it's letrozole, anastrozole, or exemestane. This was one of the subgroup analysis from letrozole, and as you can see, again, the bone-dominant disease does more favorably with the aromatase inhibitors rather than with tamoxifen. As for the selective estrogen receptor downregulators, such as fulvestrant, you do get better results. This was data coming out of the first trial versus anastrozole. But as you can see here, if you look at the complete remission as well as the partial remission, it is not really higher than the anastrozole. What you do get is an objective response and a clinical benefit better than